Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote doctor speaker. Now, with much pleasure and honor, I would like to welcome a very renowned doctor, Dr. JPS Sawhney. Welcome to our platform, sir.
Thank you.
Sir is the chairman in the Department of Cardiology at Sri Ganga Ram Hospital, Delhi. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is FH, under recognized and undertreated. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin with. Over to you, sir.
Thank you, Shriyan and IJCP, for giving me this opportunity to share with you a topic which is a clinical entity which we thought once a rare condition, a genetic disorder, but now with our own experience and the genetic testing which we did for our patients, we found this is not a rare disease. It is underdiagnosed and undertreated, what we say familial hypercholesterolemia. This is the second commonest uh, disorder of lipid metabolism after the lipoprotein little a, which is the most common, and FH is second most common disease which has got a autosomal dominant inheritance. Dear friends, uh, with this introduction, I'd like to discuss with you that for cardiovascular disease, atherosclerotic cardiovascular disease, the various risk factors are well known to you, like smoking, hypertension, diabetes, stress, and many more, and central obesity. But the most important risk factor is the lipid disorder, the LDL or non-HDL cholesterol, which enters into the formation of atheroma. The LDL's contribution through diet is only 15 to 20%. 80% is manufactured by the liver. And as I said, this is the second most common genetic disorder. And it is not rare disease. We don't look for it. And that's why we miss this condition in clinical practice. I will briefly discuss with you the global data and the data of our country, which we did a research on that, and why this clinical entity is important, particularly in patients those who have got young heart attack. That means heart attack below the age of 55 for men and below the age of 65 for women. So this disease, for last few years, 2013 data showed that only 1% of the FH were diagnosed even in developed nations like USA, Australia, and Japan. But Scandinavian countries, the UK, Switzerland, the pickup rate of FH in the society was high, up to the tune of 40 to 70%. But last 10 years, in one full decade, the awareness program came up globally, and we were also partner to that trial. And then we have given so many talks, lectures to our colleagues in the country, and now the pickup rate has increased to almost 10%. So 10% of the FH population is getting diagnosed clinically now. If you look at the prevalence of this disease, it is approximately 40 to 45 million population in the world. And where we stay, in Southeast Asia, South Asia, there the prevalence is the highest in the world. And it is estimated now that approximately 5 million population in India is suffering from familial hypercholesterolemia. We know there are two types. One is the heterozygous and another one is homozygous. The homozygous, fortunately, is very rare, 1 in 5 lakh or 1 in 10 lakhs population. Generally, these children, they present in first to second decade with no receptor on the hepatocytes, and the LDL levels are above 450 to 500 milligram generally. They come with heart attack or strokes. We had experience of 30 patients now in our country, and we found many of them, they have come with heart attack at the age of 10, stroke at the age of 10 and 12 years, and they had to undergo even bypass surgery or even the management for stroke. So this unfortunately is a rare condition. But familial hypercholesterolemia of heterozygous variety is quite common. 1 in 250 population, generally they have cholesterol levels quite high, above 150 to 200 milligram, above 190 is very common. Generally, their receptors on the hepatocytes are less compared to general population. And these receptors were discovered by Dr. Brown and Goldstein in 1985, and they got the Nobel Prize in medicine for this entity. Now you can see that we have almost 38 years after the discovery of this receptors and clinical entity of FH, we are still not diagnosing the patient of FH in the society. We are underdiagnosis and undertreating this condition. So let me go through our own data first. This was our first publication, which was there in the Indian Heart Journal a few years ago, where we look into the 600 patient of FH, and we found 15% patient had the young population have the FH. So there are many other methods of detecting, but the most common method is Dutch Lipid Clinical Network criteria. Now this is the criteria on which we generally take patient of young heart attack, less than 55 men or less than 60 women, and for that this scoring system is there. You get 2 points for that, and you have to look for the similar type of cardiovascular disease or atherosclerotic cardiovascular disease in the family of first degree relative or even second degree relatives having CAD or peripheral vascular disease or stroke or sudden history of sudden cardiac death. So these are, if you get that type of history, you get another 1 point. Then we look into the lipid profile, the LDL cholesterol. And if the LDL cholesterol is above 150 to between 90, then we get 1 point. But if it is above 190, you get straight with 3 points. So it is very common that you have a premature CAD, which is in our country is 3 times more than of the rest of the world. What I meant to say that premature CAD in our country is in 50% of the population, both men and women, as against 15% in globally, 3 times more. So you get straightway 2 points for that. If you spend some time with the patient and dig out the family history, you get another 1 point. And if the cholesterol is above 190, you straightway get 6 points. And 6 point, what we say, is the potential FH, which is probable plus definite group. So definite is 1 if the score is above 8, probable is 6 to 8 points, and possible is 3 to 5. Above 6 or 6 and above 6 has been validated by the gold standard of diagnosing FH by genetic testing. We look for the DNA analysis of functional mutation in the LDLR receptors, ApoB receptors, and PCSK9 receptor, and many more receptors are now available. And if those genetic tests are positive, you get straightway 8 points. But since genetic testing is not commonly available in our country, so we rely on phenotype diagnosis using the Dutch Lipid Clinical Network criteria, which I've just discussed with you. So after looking at the history and LDL cholesterol, we look into the physical examination. And the most common thing sometimes we see is the arcus cornealis, a semicircular gray type of deposition over the cornea. You can see here in the figure, and in that type of cornea, if it is there, and if you are a young man below 45, you get straightway 4 points. So if a person of young MI has got arcus, you are straightway say that this is FH, nothing else but FH. But the problem comes that in clinical practice, around 20 to 30% patients, those who come to you in the hospital with the coronary artery disease symptom, they are already on statin. But this scoring system is given on the basis of statin naive population. So we have got now what we say, a type of adjustment factor for each and every statin for different doses. For example, I had a patient few months ago who has come with acute heart MI, and his LDL was 110 and he was taking already atorvastatin 20 milligram. Now to get a statin naive status, for 20 milligram you can see you have to multiply with 1.8, which is the adjustment factor. So 1.8 into 110 comes to 198, and 198 means you score 3. You get 3 points because above 190 LDL your score is 3. So like that, for rosuvastatin and HMI, this scoring system is available. So what we have learned is that the guidelines are very clear, ESC 2019, that any young patient with heart attack who has got high cholesterol, always look for FH. And once you diagnose FH, these patients generally have high cholesterol, very high cholesterol. Alone high dose of statin may not be enough. You have to give, along with the statin, You add a 40 milligram of Rosuva or 80 milligram of atorvastatin along with 10 milligram azithromycin to this population, and wait for 4 weeks. If the levels are not reached below 55, then we have to add bempedoic acid. And if still levels are not reached, then we have to use PCSK9 inhibitors. And now soon we are getting in January another drug called inclisiran, a new drug which is coming up, which inhibits the synthesis of PCSK9. But this has advantage that we have to give this injection only twice a year as against 26 injection of PCSK9 inhibitors, although they both are very costly drugs. But at the same time, the guidelines are very clear that the treatment of familial hypercholesterolemia, even if you have made them clinically, is not complete without doing a family cascade screening. So this is the importance of FH. That in FH population, you treat an index patient whom you have diagnosed with statin or non-statin drugs, but you have to look for the family members also. That is the advantage because it is a genetic disease. So what is the importance of cascade screening? Cascade screening is nothing but the screening of siblings and the children above the age of 5 years for lipid profile. And this is a very simple, effective alternative to genetic testing. Although genetic testing is the gold standard, what I've told, but if a person has got a FH and his son or daughter has got LDL above 150, or his brother or sister has got LDL above 160, they are the potential carrier of familial hypercholesterolemia. So we pick up this population in the family, those who are not symptomatic at the moment, but they are carrier. And if you don't treat them now, they all will get heart attack at the age of between 40 to 60. And for that reason now the guidelines have suggested for children, start them at small dose of statin along with lifestyle modification and bring their LDL to less than 135 milligram. But for adult, bring it below 70 milligram. So that is very important. So, by diagnosing a case of FH, we do not identify a case but a family at risk. So, this is the importance of diagnosing FH in the society. You are not only treating an FH patient who had a heart attack by giving them all the treatment for heart attack and along with lipid lowering treatment, but the family at risk is picked up and we can prevent the disease prematurely in the society by treating them in time. So this is the algorithm. The young heart attack, apply Dutch lipid clinical criteria, adjustment factor if needed, score is 6 and above, then you have to treat them pharmacological. As I said, most of them, they will require a combination treatment, maybe bempedoic acid and PCSK or inclisiran also. And cascade screening, look for lipid and genetic testing. If the carrier of FH is found, then should treat them with lifestyle modification. But here they need low to moderate doses of statin to reach the goal of less than 135 for a child or less than 70 for an adult. So this was our study which we extended subsequently after our first publication. Now we have got 1200 patients, maybe more now. And in that what we found, when we used the Dutch lipid clinical criteria, we found the definite people, those who have got score of 8 was seen in almost 4% of population, and those who have got probable score between 6 and 8, they were almost 13% population. So this shows that approximately 17%, not 15 what we thought initially, are suffering from FH in the society with young heart attack. And when we look into the similar data coming from USA, there they found it is 10%. And the study came from the Australia also, from Sydney, and there they found in 14% of population. So our population, the FH incidence or prevalence is much higher compared to rest of the world. So this is one of the important cause of premature heart attack in our country. Now what we learned was another important thing. We started looking into the risk factors like diabetes, smoking, hypertension, and cholesterol. As we found the patients, those who are having the definite, probable and all that, those who are having the definite and probable, they generally have higher cholesterol level, but the risk factor was associated less. So you must learn one important rule in clinical practice. If you find a young heart attack patient and if you're not finding a common risk factor like smoking or diabetes, think, and he's got cholesterol which is high, above 130, think that he is a case of FH. So this is a very important rule to learn in clinical practice. This was our publication in Atherosclerosis Journal also subsequently. And then we look into the cascade screening and use the genetic testing now for the time. And this was a study done by Dr. Verma and Dr. Nitika, and we participated in this trial. And here what we did, we diagnosed 100 patients on based off Dutch Lipid Clinical Network criteria. And then we did genetic testing on them. And those who came positive with genetic testing, we did cascade screening, genetic testing of the cascade screening of the family members. So what we found that the around 50% of people, those who have got more than 60 to 70% of people, those who have got definite and probable FH, they have the genetic test positive. But most of them were LDL receptor positive. Very few are PCSK9 and ApoB mutation. So here you can see here in this slide that 134 family members, when we did the genetic testing, they were not aware of any, they were suffering. So 95 people had positive genetic testing. That shows that the carrier of FH is not that uncommon. So genetic testing has opened our eyes that this disease is existing in the society. We are not looking for that. 16 of them were younger than 18 years of age. So this is very interesting. So, can we give statin to children? Yes, we should give, along with lifestyle modification. If the LDL levels are very high, then to prevent their premature heart disease, we can give them a small dose of statin. And it should be started as early as possible. What we have learned now, that the homozygous people they get at the age of 12 or 13 years, heterozygous 35 to 50 years, and normal person beyond 50-55 years. So what we found that we start statin very early at the age of 10 years, then we can shift the disease by almost 2 decades. Start little later, maybe by 15 years. So the drug is safe. It do not interfere with the puberty or the sexual growth of a child, and their growth is very good even if they are taking a small to moderate doses of statin. And we are preventing definitely a premature CAD which has happened to their father or their uncle. This is a study done on children and 20 years of follow-up of using statin in FH population, those who have got genetic carrier. And what we can see here, as they started early on statin treatment, the progression of the disease was checked. The carotid intermediate thickness, the CT angiogram were all free, whereas their father, they started above the age of 50 and they got some benefit, but it was not as good as the children. And now we have got PCSK9 data also for young population of homozygous population, because we know they do not have any receptors, and that is a big challenge. So statin and non-statin drugs are useful, but they are not reducing from 450 LDL to maybe 350 LDL. But PCSK9 inhibitors now are found to be safe in children, and they have shown that they reduce LDL by another 50-60%. Still, a lot of patients do not reach the target of 135 or maybe. The other genetic study was also done in our center, and we found the genetic heterogeneity of FH in our country. The variants observed were different from those described in Western population. So next generation sequencing technology helped identify new mutation in ApoB gene, suggesting that in less studied population, it is better to sequence the whole gene rather than the test for specific mutation. Homozygous population, as I said, 30 patients. We did a study and we found that the drug was given to them, Evlucamab PCSK9. We found that it was very well tolerated and it was safe, but we could not reach the guideline directed the LDL because the receptors were hardly there in them. The other thing what we started looking into every patient of lipid disorder was the lipoprotein little a. And this is a thing which if the levels are above 50 milligram, we say it is elevated, and it is associated with increased cardiovascular disease, cardiovascular mortality, aortic valve disease, and stroke. And what we found in our study of more than 1,000 patients that the elevated LPA was high in young population, no doubt, but it is associated with severity of disease. But the most important thing what we found was the prevalence of lipoprotein little a elevation was much higher in FH population than the general population, up to almost 40%. So that shows if you have a FH and lipoprotein little a, which should be done at least once in lifetime for everybody, because it is a genetically determined risk factor for the hereditary risk factor for dyslipidemia. So if you have got LP high and FH, then this combination is the deadly combination. You have got double heritable risk factor which can cause a very premature heart disease in a very young age and can have an aggressive progression of disease. We have been partner to Dr. Kaushik Ray's Familial Hypercholesterolemia study collaboration. It is a global study now, almost in 70 countries going on, and more than 70,000 population have been now studied on that. We have also participated up in from our country, and we have given 350 patients from our only stent center from the country, and we started looking into the various aspect, the onset of disease. So this is basically a registry, a global registry, which has helped us to identify the lacunas in the diagnosis of FH, and also give us that how frequently and how early we get a disease. So this is very important, and most of people have used Dutch lipid clinical criteria. Genetic testing was done in few countries, of course. And before closing my talk, dear friend, just to give you an idea that you know this famous Mona Lisa portrait, which was done on a subject called Lisa Gherardini. She was the wife of a very famous businessman from Paris. And Leonardo da Vinci, the artist who made this portrait in 1503. You can see here the genithalesma in the left eye, Mona Lisa. And if you look at this protrusion, this is the tendon gelthoma. It is believed that Mona Lisa probably had FH and she died because of coronary artery disease. So in conclusion, dear friends, FH is the most common metabolic disorder. Despite significant health risks, it is inadequately diagnosed and managed in our country and globally also. It's not rare, we miss it because we don't look for it. Dutch lipid criteria is a simple way to diagnose FH clinically. One should suspect in patient of premature CAD and lipid above 160. Cascade screening using lipid profile is most effective way of preventing premature CAD in the population by starting treatments, lifestyle modification and statin treatment. In our study, we found FH is quite common in young heart attack patient of the tune of 17, and if we pick up the genetic carrier in the family, we can definitely prevent a premature CAD in the society. High dose of statin with or without ezetimibe and bempedoic acid and PCSK9 and inclisiran will be very effective to reach the target of goal what we have suggested. Thank you very much for listening to me. Over to Orion. Sriyon, back to you. And if there are any questions, we will like to take up that questions. And
Thank you so much, sir, for your lovely presentation, sir. We have some questions from our audience if you like to take that up.
sure.
Thank you, sir. So, sir, the first question from our audience is, can you share some successful case studies or best practice from your clinical experience regarding the management of FH patients?
Yes, as I said, we have a lot of patients, 330 or 40 patients we have already given to the Dr. Kaushik Ray in the global registry, and all these patients are now on large doses of statin, and they are reaching the goal of less than 55 for this heart attack population, and we have picked up on average from each family at least 2 or 3 more carriers, and we have put them into the drugs, and I have got few children, 16 children under me now, those who are carriers and they are on statin. The youngest one is 6-year-old. She was on 5 milligram of rosuvastatin, and her LDL has come down to below 135, and all children are doing well. Most of them are tolerating the drug very well. There was no history of any myalgia in these children, and the adults, of course, some of them they could not tolerate. Then we have to give them PCSK9 inhibitor, and now next month onward we'll getting option of inclisiran also.
Thank you so much, sir. The next question from our audience is, what are the challenges and barriers of FH treatment adherence, and how can we address them to improve patient outcome?
Yes. So the challenge which we faced is that the diagnosis challenge, because most of the even my colleagues, those who are cardiologists in the country, are missing this time. They accept it that they are missing it because they don't look for it. That's the problem. They think that every a young heart attack with high cholesterol, everyone is treated like any case of dyslipidemia. But once we look into the criteria of FH, which is not that difficult, we'll able to identify index scan and the family and then prevent. So the problem is that we have a barrier that we don't look for it. Any young heart attack patient. Number second is that these most of them they have very high cholesterol, and if they have high lipoprotein little a also, as I told you in one of our study, so then there is some resistance to statin also. We have to use non-statin drugs. Now fortunately we have got bempedoic acid and PCSK9, but it's very costly drug, PCSK9 inhibitor. So that is a big problem which we are facing. It is another barrier. We are unable to reach the goal because the cost of the drug is very high. Second barrier is that when I diagnose FH in a family and I asked for genetic testing or the lipid profile for the children, particularly brother sister, they get angry. They do not resist, but the children, the parents sometimes they resist. I ask them, what is the reason why you resist? They say that if we diagnose FH in my child, he is labeled as a genetic patient, and we do not want to give this stigma to our child. So there may be social problem in future like marriage and other things. That is another problem. Third problem which we face is that if a patient of FH diagnosed and has a heart attack, has undergone PTCA, and now is getting discharged, if we make a diagnosis of familial hypercholesterolemia in the discharge slip, this is considered as a genetic disease, and for that the insurance company they reject it. So this is another problem which we face in our country. I think we need to address these issues in clinical practice.
Thank you, sir. The next question from our audience is: what are the long term cardiovascular risks associated with untreated FH, and how does it compare to non FH individual with high cholesterol?
You see, the FH population will get disease in younger age, between third, fourth decade to maximum fifth to sixth decade, at least 20 years earlier than non-FH population. So that is the most important danger. If you don't treat them, if you don't pick them, so this is about the index case. Now, if you do not pick up a carrier of FH in the society, then he or she will get again disease between 35 to 50 years with heart attack or stroke. So that is a big thing which if we should do that. As I said, we have 5 million population in our country suffering from FH. Maybe more, I think, is underestimation. And if we pick up the other, so rule is simple. If a young heart attack patient comes to you in the society, start looking for FH in that individual. And the criteria which I told you, family history is very important. Look for LDL cholesterol, and don't forget to look at lift the upper eyelid and look for arcus cornealis. If the arcus is there, which is there, but that arcus should be young, less than 50 years or 45 years, not the old. The senile arcus is not considered as important, but the young age arcus is important. So if you pick this clinical picture and label them as an FH, some of those patients are able to easily afford, because the genetic testing is not costly now. It's 15,000 rupees. Some centers are even taking 10,000. Now many more centers are now doing genetic testing of FH, like hypertrophic cardiomyopathy. So this, if you confirm the diagnosis, then all the more it become established, the diagnosis is established, they have to be treated, and most of them has to be on statin. They cannot escape that. Otherwise, they all will get heart attack between 35 to 55 years of age.
Thank you so much, sir. The last question from our audience is: what are the typical clinical features and signs that should raise suspicious of FH in patients?
You see, if you look at the homozygous, which is very, very rare, generally they go to skin specialist because they have got xanthoma, they have got the tuberous sclerosis over the ankle, knee joint, on the back of the, and also over the ankle, what we say, the tendon xanthoma and arcus, of course. So generally they are going to the skin specialist for this problem. From there, these our dermatologist colleagues, they get the lipid and then they send us to us. It becomes easy for homozygous. Problem comes about heterozygous. They do not have any clinical features. As I told you, only clinical feature I have found clinically is the arcus. Arcus cornealis coming in a young person is a good clinical picture which gives you that this man or patient is got high cholesterol level. Of course, doing a lipid profile and having very high cholesterol above 190 milligram, young heart attack, these are the one clinical features which gives you an evidence that possibly this person has got the FH.
Thank you so much, sir, for answering all our questions. Uh, Before concluding today's session, sir, any last remarks from you?
You see, my only suggestion to my colleagues is that this genetic disease is one of the important cause why we get heart attack in our country 10 years earlier. What we have analyzed that we get heart attack 10 years earlier compared to rest of the world. 50% of the heart attack in our country comes below the age of 50, which is 3 times more than the rest of the world. We started analyzing the risk factor. What is the reason behind it? Number one is that we get risk factor of diabetes, blood pressure much earlier compared to rest of the world. Number two, we have smoking a separate problem. Besides this smoking cigarette, we have BDs, we have a tobacco chewing, which is additional burden which is not seen in rest of the world. Third is the central obesity, what we say metabolic syndrome. It is 42% in our country compared to 20% in rest of the world. Central obesity, and that leads to a typical type of lipid abnormality of our country: high triglyceride, low HDL cholesterol, and small dense LDL cholesterol. Fourthly is the high prevalence of genetic factor in our country. Number one, LPA. Globally, the prevalence is 15 to 20%. In Indian population, studies have come from various parts of the world, including India, our own study, that it is 25% in general public. FH, familial hypercholesterolemia, is 10 to 15, 12 to 14% or 15% in the rest of the world. It is more than 17% in our country. So, and then we have a bad food habits. We have got lack of exercise. Our cooking methods are not good. We, being a vegetarian, many times we indulge into a lot of vegetarian food, carbohydrate food, high intake of carbohydrate food, sweets, carbohydrate. So those simple carbohydrates are most dangerous. And cooking method like the heating and reheating the oils, using wrong oils. So these are the various methods, reasons for which we have found now we get heart attack in our country in earlier. And among them, one of the key factor is a genetic factor, which we have discussed today about FH. So one should look for FH in every young heart attack population by looking at their lipids, looking at their family history, looking at their ARCUS, and by that, if a person can afford, then get a genetic testing also in them, then you will able to achieve able to diagnose and prevent a lot of premature heart attacks or strokes in the family or in the society by picking up the carriers of FH. So that is what I want to convey now to my colleagues, that this is the crux of problem which we face and we are ignoring. So the blood pressure has got some symptom, diabetes has got some symptom, cholesterol has no symptom. Unless and you get it done. So that's why we have suggested after the age of 18, when a child goes to college, he should get his lipid profile and try to correct it if there is a abnormality by at least lifestyle or by drugs if needed be. I think we can.
Thank you so much, sir. And thank you again for joining us today. With your permission, I would like to conclude today's session. Thank you.
Thank you very much.